afternoon, everyone, and welcome to Nutrition Hot Topics for May 2021. I'm going to hand off to Dr. Marielena Muzaki to introduce Dr. Orkin. Dr. Muzaki.
Okay, thank you. So it is a great pleasure to introduce Dr. Orkin, who I think most, if not all of you already know. Dr. Orkin has been here for a while, but she did her med school at the University of Connecticut, and then she came to CCHMC to do her residency here. And thankfully, for all of us, she stayed here to do her GI fellowship, where she realized she loves nutrition. And then she stayed to do her advanced nutrition fellowship, which is what she's finishing now. And she has excelled in everything she has done. Throughout her studies, she has truly been a major advocate for patients, and she has shown a passion for the socioeconomic aspects of care. So this presentation today is proof of that, and you'll see her work in the area of food insecurity, specifically for pediatric non-alcoholic fatty liver disease. So Dr. Orkin, take it away.
Thank you for that kind introduction, and thank you all for coming to my talk today, where I'll be discussing my work looking at food insecurity in pediatric non-alcoholic fatty liver disease. And just to warn you, I do have some technical difficulties intermittently, so I may have to switch in and out of the slideshow just depending, but hopefully that will not happen. So the title of my talk today is, let's see if we can advance this. Nope. Oh, there we go. Is food insecurity and pediatric non-alcoholic fatty liver disease severity. And so the objectives of my talk today are a few, and they are to define social determinants of health and discuss the importance of them in models of chronic disease, for us to understand what food insecurity is and some ways that we can think about screening for it, to review the definition of non-alcoholic fatty liver disease, or NAFLD, and talk about some of the metabolic pathways that are implicated in its development and its progression. And then to explore some possible mechanisms which may link food insecurity with non-alcoholic fatty liver disease severity. And then finally, at the end of this talk, I'll share some of the data I've collected during my research in the past 1.5 years from patients here with non-alcoholic fatty liver disease and variable food security states. So just to start, to talk a little bit about social determinants of health for those who may not be familiar. The definition really encompasses the conditions in the environment where people are born, where they live, work, play, and worship and age, and they affect a wide range of health, functioning, and quality of life outcomes and risks. And they fall into many domains. There's 5 of them defined by Healthy People 2030, and they include economic stability, access to education that's of good quality, access to quality healthcare, your neighborhood and your built environment, and finally, your social and community context. And I think Dr. Riza Lovizo-Mori said it best, the former president of the Robert Wood Johnson Foundation, when she said, now a child's life expectancy is predicted more by his zip code than his genetic code. And I think this really sums up kind of my take on social determinants of health and thinking about the care of children. And so what are some of the roles that we know about of social determinants of health and illness? And I just wanted to focus on the next few slides on publications that have all come out of Cincinnati Children's and in the last several years, just showing the wide range of patient populations and areas that this spills over into. And so there was a publication by Madzia and et al. In 2018. And this looked at the access to patients, the access to green space of patients with behavioral issues, and screened them over 5 years time, and saw that with increased availability to green space exposure, there was a statistically significant improvement in behaviors. And then Dr. Riney in our emergency room looked at census tract level of patients presenting in the emergency room, and found that kids coming from census tracts with lower socioeconomic status were more likely to use the emergency medical services and ambulance, that they were less ill when they presented at triage, and that fewer of those transports resulted in hospital admissions. And so this is really discussing the potential for limited transportation alternatives and potentially diminished alternatives for preventative care in the community and health literacy issues. Dr. Andrus in our PICU looked at child poverty and PICU admission and length of stay. And when they broke poverty into quintiles and compared the lowest quintile and the highest quintile of child poverty, they found that kids from the highest quintile had a much longer length of stay in the PICU as compared to children from the lowest poverty quintile. Dr. Beck looked at asthma readmissions at Cincinnati Children's and found that African-American kids were twice as likely as white kids to be readmitted for asthma exacerbations. And our own Dr. Wadwani from GI here, who has since moved on, looked at liver transplantation outcomes in children from high and low deprivation neighborhoods and found that the graft survival and patient survival was actually diminished in children from more deprived neighborhoods. And then finally, another recent publication from Dr. Beck and colleagues looking at the inpatient bed days as a whole at Cincinnati Children as it related to census tracts around the hospital showed that children from the highest poverty quintile had the highest inpatient bed days as compared to kids from lower poverty quintiles. And just looking at that, what that looks like in a really nice figure, you can see the poverty quintiles are divided by the multiple colors here, and you can see it's there is some gradation depending on the illness being looked at, but in general, those from higher poverty quintiles contributed to a much longer inpatient bed stay. And then there's kind of a hotspot map to the right showing you the darker red, meaning the more bed days contributed and kind of where these children are coming from. And then these are other publications in children as well, not from Cincinnati Children's, looking at outcomes in various disease processes and showing that multiple outcomes are dependent upon or associated with markers of social determinants of health and socioeconomic status. So I hope with this, I've shown you that every single subspecialty, no matter what division you're in or who you care for, should care about this. It's really important and it really impacts our patients. So moving on, just talking a little bit about food insecurity, what it is and why it matters. So the USDA has developed these definitions, working definitions that I'll talk about. So food security is defined as households always having enough access to food for all members of the household so that they can lead an active and healthy lifestyle. And then there are degrees of lower food security. So low, meaning you get enough food to not disrupt kind of your eating patterns, but it's not necessarily a varied diet, and you may need to access emergency food sources. And then very low food security, meaning that it disrupts your eating patterns, that you have to reduce intake, and that you have reduced resources as a result of it. And so what is the impact of food insecurity? Before COVID, the impact was 1 in 5 households in the US with children endorsed some degree of food insecurity, and that has gone up significantly since COVID, which is not in the scope of this talk, but has had a huge impact on the landscape of food security for children in the US. Costs as a result of food insecurity have a big impact on the healthcare system, with one publication estimating that it contributes to at least $200 billion in care in the US annually. And that food insecurity is associated with many chronic conditions, which I'm going to talk about in the slides to come. So what is the USDA screener, which I've referenced already? So this is developed by the US Department of Agriculture. It's an 18-question module, and the answers are subcategorized into multiple different areas of the house. So depending on how you group the answers, you can look at the total household and then break it down into adult and child food security as well. And depending on how many affirmative responses you get to the 18 questions, you can classify the food security in various levels of severity. And you can look at it in binary, just yes, no. So it gives you options for kind of more granular, detailed information at the household level. I will say that there has been another recent publication since the USDA screener, which is just looking at these two questions, and this was by Hagar et al. And these are the two questions that I would say most people are familiar with, because many divisions around the hospital use these two questions. And they are, within the past 12 months, we were worried whether our food would run out. And the second question is, within the past 12 months, the food we bought just didn't last. And the patients in this study answered these two questions, and they answered the USDA 18 question screener. And the authors found that these two questions alone were 97% sensitive and 83% specific for food insecurity. So I know the PPC definitely uses these questions. In GI, we use these questions during the hospital stay. I believe most patients are supposed to be asked these questions. And I don't know how many other subspecialties use them, but I would say these are probably the two questions people are most familiar with when they think about food insecurity screening. So what are some of the nutritional impacts that may affect our patients as a result of food insecurity? And this list is by no means exhaustive, but it's kind of some of the things I think about when talking to patients. So things like watering down formulas, irregular eating patterns, potentially inexpensive, high density, high calorie food, not being able to get the types of food that culturally the family would want, or the types of food that the family would ideally want to serve their children, and then consuming medications and foods past their expiration date. And so certainly when I see patients in GI, especially ones who are coming to me for problems with poor weight gain, these are questions that I explore with families. And I know as dietitians, probably all of you are familiar talking with families about how they're preparing formulas and what the mixing ratios are, but I think I'm often surprised when I ask families and they open up and tell me that they've been diluting and to make ends meet or stretch the formulas a bit longer. So really important to actually have those conversations face to face, and I think you can learn a lot by having that time to have conversations with family. And this is just more like a question that I have for the group that's come up in other groups that I've talked with that I think is interesting. So if a family were to receive meals from an emergency food source, such as a pantry or church or the free store, would you personally consider them to be food secure or food insecure? And there's not a right or wrong answer to this per se, but I definitely think I've asked families the two question screener, and they say that there's no issue. And then when you talk to them about their meals, you find out, they're getting emergency food sources. And so, potentially the way that I think about them before learning that is different. And so that's why even when you do those two questions, spending time with the family to delve a little deeper, I think is really important. And this is, I want to show you guys a map that's from Map the Meal Gap from feedingamerica.org, just looking at food insecurity. And so this is looking at data from the state level, which is obtained from the current population survey, which is obtained once per year. And then they do regression modeling to really break down the responses to look at the county level. And so there are definitely limitations to this in that the data lags behind. It's a year, only released a year at a time, and it's not as granular as potentially we would like it. And so just looking at Ohio here, you can see the data that this platform provides, but it's no means useful in the clinical setting when we're thinking about patients. And that's what led me to one of my first projects during fellowship, which was to look at the barriers encountered by our patients in NAFLD clinic and also in our general GI clinics, just as a comparison. And I think, not to focus on this, but the most important finding, I thought, was that patients from the NAFL clinic, the biggest barrier that they encountered across all the barriers you can see on the x-axis that we asked about was food insecurity. And this is really particularly important to pediatric NAFLD, which I'll talk about in the coming slides. But in pediatrics, we don't have any approved medications for the treatment of NAFLD. The mainstay of therapy is dietary and lifestyle interventions. And so if we're not aware of these barriers present, we really can't effectively help families to do these interventions because we don't know the undercurrent of what's going on in their home. And I actually tracked some of these patients longitudinally and retrieved surveys multiple times over a year's time. And the really important finding I thought was that families who endorsed food insecurity at our first ever time capturing a survey from them were 27-fold more likely to have continued unmet social needs persist than those who were food secure. So is the food insecurity really a proxy for other issues with social determinants of health, other barriers going on in the patient's lives? But I do think it's kind of a red flag where you should know that patient is at risk and they warrant more attention and thoughtfulness about our resources. So now I want to spend a little bit of time talking about the literature that exists about the role of food insecurity in illness. And these studies are in adults. There are no studies here of children that I will present until getting to my own, but looking at food insecurity and type 2 diabetes, an NHANES study looked at over 4,000 adults over 20 years of age, and they used that USDA screener to categorize their degree of food insecurity. And they broke it up into mild, moderate, and severe. And then they adjusted for socio-demographic and kind of family history factors, and still found, after adjusting for all of that, those with more severe food insecurity were more likely to have type 2 diabetes. And even after controlling for BMI, this persisted. And so some of the proposed mechanisms that the authors discuss are the things that we've already talked about, like consumption of nutritionally poor but calorically dense food, and the cyclic nature of food availability, in particular in this population, may lead to swings in blood glucoses, that there's chronic stress, and that may be associated with higher visceral adiposity and cortisol. In addition, higher CRPs and markers in the blood of inflammation have been found in patients with type 2 diabetes and food insecurity. And then in addition, there may be some trade-offs where patients are worrying about food, worrying about rent, and so those are leveraged against purchasing the anti-diabetic medications, which may play a role. And then looking a little bit about food insecurity and other cardiometabolic conditions in adults, this was another NHANES study, larger, over 2,000 patients, 20,000 patients, and it was basically looking at patients with various cardiometabolic conditions and then comparing the rate of food insecurity in people with the condition and without. And across the board, for all of the conditions I've listed here, type 2 diabetes, high blood pressure, coronary artery disease, CHF, and obesity, all of these patients with these chronic conditions had a higher prevalence of food insecurity than people who did not. So I think this just speaks to the role that food insecurity is extremely relevant to a host of chronic illnesses. And then what about food insecurity and obesity? This one is really complicated. I don't think there's a clear answer. Really, there's a lot of competing influences. So food insecurity, for the reasons we've discussed, can be obesogenic in terms of the high caloric density food, but at extremes can also lead to weight loss when the food insecurity is so severe that portions are reduced or cut. And there's multiple studies on this, and the results are mixed for sure. What in general, I would say I have found in the review of the literature, it looks like food insecurity is more associated with obesity in women than in men. And some studies looking at food insecurity in the diet in particular show what we've talked about, the increased consumption of nutritionally poor but calorically dense food, that in children who are food insecure, they have a lower healthy eating index, that there's increased consumption of microwavable and quick frozen food in kids who are food insecure, and also more of the calories in the diet come from fat and from sugar. And this is an image from an old study. I actually looked in the literature for a newer updated version and I couldn't find one, but it's basically showing the relationship between cost and the density of food. And you can see that the cheapest food along the x-axis correlates with some of the highest energy dense food along the y-axis. And so kind of my question to the group is, how can we expect families to modify their food environment when this is the reality for many families, and many more now in the setting of COVID and job loss and everything else going on? So that brings me to a little bit of a discussion about non-alcoholic fatty liver disease. And I just wasn't sure the audience, how many people are familiar with it. And I wanted to do a very brief overview of what it is and why it matters. So non-alcoholic fatty liver disease, or NAFLD, is really a broad range of disease severity. It can range from just bland steatosis or fat in the liver without inflammation, and then progress to inflammation, which is what we call steatohepatitis or NASH, and then progress on from that to fibrosis and scarring. And that's what leads to end-stage liver disease and cirrhosis, which is actually an indication for liver transplantation, which I will talk about. The way that we diagnose non-alcoholic fatty liver disease is we suspect it when liver enzymes are high in the blood, but the real gold standard to diagnose is by a liver biopsy. And the reason I bring that up is because that is not possible at many pediatric centers. I think we take that for granted here, but with the rising prevalence of obesity and NAFLD, the patients are overwhelming the system, and it's challenging for patients to obtain the liver biopsy in the numbers of kids that are presenting. And another option would be magnetic resonance imaging, or MRI, of the liver, looking at the amount of fat in the liver and how stiff the liver is. And that is another alternative. While not invasive, it is expensive and time consuming, and not all centers have that expertise either. So that's something to think about. And on either modality, either liver biopsy or MRI imaging, when you have a hepatic fat fraction, or the amount of fat in the liver is 5% or higher, that's how you would meet the meet criteria for NAFLD, assuming you've ruled out other possible etiologies like autoimmune hepatitis, other metabolic disorders, or alcohol consumption. And then looking here at the scope of the problem a little bit further. So NAFLD is the leading cause of chronic liver disease in children, and it's soon to be the leading cause of liver transplantation in adults. It has a huge cost burden on the healthcare system, and we don't really know about risk factors for longitudinal progression in children. So I hope that I've convinced you that NAFLD is a huge problem. It has big implications for the future of children, and kind of how we diagnose this, work it up, and as they age into adulthood, kind of carry that on with them. So talking about how kind of the pathways that are implicated in NAFLD, I wanted to talk about this with the key driver, I would say one of the main drivers being insulin resistance. And this results in NAFLD in multiple different ways. Probably three main pathways I wanted to talk about. One would be that insulin resistance results in increased de novo lipogenesis within the liver. In addition, because of insulin resistance, lipolysis in the adipose tissue is not inhibited. And so as the adipose tissue goes through lipolysis, free fatty acids are released from the adipose tissue into the bloodstream. And these flow out of the bloodstream and go and are absorbed back up into the liver through the portal system, further contributing to the problem of fat accumulation in the liver. And then in addition, insulin resistance results in adipose tissue dysfunction. And adipose tissue itself is responsible for secretion of different cytokines and adipokines, for example, IL-6 and tumor necrosis factor alpha, which are pro-inflammatory. And there have been studies in patients who have their serum levels of these cytokines checked and then go through weight, are able to lose weight and show that these levels drop. So there's something about the adipose tissue itself, which acts as basically an organ that's contributing to this metabolic derangement. Once we have the fat accumulation in the liver in the form of triglycerides and free fatty acids, this kind of overwhelms the mitochondria, which are the site of fatty acid oxidation. And when the mitochondria get stressed, they can collapse under the pressure of the lipid load. And once that happens, we have kind of impaired fat homeostasis, increased oxidative stress and reactive oxygen species. And this goes on to activate inflammation within the liver, which is presumed to lead to fibrosis. And then in another pathway, which I'm not really talking about further in this talk, but I thought was worth bringing up, in NAFLD, there is a growing body of evidence talking about the altered gut flora and how the gut is more permeable. There's more free fatty acid absorption. There's more inflammatory kind of cytokines coming from the gut itself as well. So kind of all of these pathways are implicated in the development of NAFLD and then progression as well. See here. Okay. And so just briefly touching on the known risk factors for severe NAFLD, which I've talked about already a little bit in this talk. They include severe obesity, where severe obesity is associated with more severe NAFLD. Hispanic ethnicity. There are some genetic polymorphisms that are associated with more severe NAFLD phenotypes. The presence of type 2 diabetes and insulin resistance, obstructive sleep apnea, some different medication use, male sex, and then sugar sweetened beverage consumption. And that's really mediated through fructose, which can bypass, can be absorbed right into the liver independent of insulin and contributes immediately to de novo lipogenesis and is inflammatory in that nature. So of all of these known risk factors, the ones that I've outlined in red are ones that have been shown to be associated with socioeconomic status and social determinants of health already in previous studies. So I think all of this kind of paints the picture and adds to the growing kind of story that I'm trying to weave together here, that social determinants of health have a potential to have a huge impact on NAFLD development and progression, and then specifically for me, food insecurity as that area of interest, because it ties together my interest in nutrition and social determinants of health. So that kind of is the backstory to how I got here. And so talking about the hypothesized mechanisms for my project, a lot of this pulls together the literature I've already shared with you, drawn from other chronic disease models, but really looking at food insecurity and how we get from the left side of the screen to the right. These are some of the pathways that I've come up with here, creating this schematic for how I think about it. So food insecurity and its role on diet for the reasons we've talked about before, and how increased fat and fructose intake, that your gut microbiota may be altered, as well as the cyclical nature of food availability is one arm. And then independent of diet, food insecurity itself has been associated with obviously stress, changes in serum cortisol, and our hunger cues. And so that may also play a role in the development of the insulin resistance and type 2 diabetes, which go on to cause this lipolysis from the adipose tissue that I've talked about. And then all of these pathways kind of converging on the final outcome, which is the lipotoxicity, inflammation, and steatosis that we see in NAFLD. And then these are some of the molecules that I have been, that we have been thinking about that are implicated in the nutritional contribution to NAFLD that I'm going to be talking about how we're exploring in the future. But those are including things like free fatty acids, diacylglycerols, phospholipids, ceramides, and then the cytokines resulting either from as a result of diet or from the adipose dysregulation. And so I didn't want to stress this too much, but I wanted to spend just a little time reviewing how kind of when we talk about the diet and inflammation, what are some pathways that we're talking about. And as many of you guys already know, the polyunsaturated fatty acids have variable anti and pro-inflammatory profiles. And that in general, when we think about omega-6s and omega-3s, that 6s tend to kind of go down this pathway acted upon by various enzymes. And one of the molecules that results from these enzymes is arachidonic acid, which has kind of pro-inflammatory properties, whereas the omega-3 pathway going down to the DHA and EPA have more of an anti-inflammatory profile. And obviously, these are not omegas. It's not to say that omega-6 is bad and omega-3 is good in any way, but that the ratio of these may have some impact on the inflammatory state of the host. And so that's one way that I'm thinking about nutrition as it relates to NAFLD. And then here was a paper by Ulla et al. From 2019, just looking at how carbohydrates and fat in the diet kind of can get to this end output of NAFLD, NASH, and fibrosis. And we've talked about kind of all these pathways in the previous slides, but the endoplasmic reticulum and the mitochondrial stress from the lipid loads, the increased inflammatory cytokines, and the TNF alpha IL-6 kind of things that we've talked about. So there's definitely a basis for kind of this framework to think about the diet and how it results in NAFLD and NAFLD progression. And so there's actually been 2 recent adult publications looking specifically at food insecurity and NAFLD, which are very timely. And one of them is by Golavati et al. From 2019, looking at NAFLD severity in low-income adults. And so they looked at over 2,000 adults and looked at their data from NHANES. They restricted it to low-income households and patients over 20 years of age. They were able to get labs on them, and then they did a liver ultrasound on them to look for NAFLD. And so the main finding I wanted you guys to focus on is they let's see, I think, the key is at the top, so I can't see it. But the color coding of the bars here is by the dose response of the severity of food insecurity, with the darker bars being more severe food insecurity than the lighter bars. And you can see both for NAFLD and for advanced fibrosis, those who were food insecure had a higher prevalence of both NAFLD and advanced fibrosis. And then a even more recent publication, actually from 2021, to Margot et al. And Dr. Sherman from UC actually has published this paper looking at food insecurity and MRI determination of NAFLD in patients with and without HIV. And this was a little bit of an older cohort. These were patients over 40 years of age. They were from the Miami Adult Studies on HIV, or MASH, and they had Hep C and HIV in variable combinations with and without both of those. They also assessed food insecurity through the USDA screener, and then their primary outcome was the presence of NAFLD through the MRI with the proton density fat fraction that I was talking about, with over 5 being consistent with NAFLD. You're also able to look at how stiff the liver is through MRI, which is kind of a surrogate marker of fibrosis. And the findings from this study that I wanted to tune you into is that you can see in the light bars here are patients who are food insecure, and the dark bars are patients who are food secure in the graph to the left. And you can see here that patients who were food insecure were more likely to have fibrosis overall and more likely to have advanced fibrosis, with the advanced fibrosis meeting statistical significance. And then I think really interestingly is the graph on the right. It's just showing you the probability for NAFLD in patients who are food insecure and food secure. And really that the point of this is that the prevalence of food insecurity will increase your probability for NAFLD across the obesity spectrum. So it really attenuates, the presence of food insecurity attenuates the impact of obesity on NAFLD. So a 5-point rise in BMI in someone who's food insecure may have a much bigger impact on their NAFLD than a patient who's food secure. And so I found that that was a really interesting finding. So with that, thank you for your time, for listening. And if there's any questions, I'd be happy to answer them.